Okay, guys, let's talk about proximal humerus fracture. Sometimes this is just called a shoulder fracture because it essentially affects the shoulder. But the fracture itself is not on the scapula, but actually on the shoulder. So this tends to be what they look like. Usually large amounts of hardware involved with this kind of fracture, which can affect range of motion for sure. So that's something we definitely have to think about as we kind of move forward with patients' rehab. Is how much hardware is in there and all that. So we'll talk about that as we talk about the rehab. So just as a reminder of anatomy, so here's our humerus. You have the head of the humerus, and then you have that greater tubercle that's going to be kind of superior aspects, that little bump superiorly. And then you see the anatomical neck and then the surgical neck. So again, anatomical neck's a little more proximal than the surgical neck. And then you have the shaft, and then you have the lesser tubercle, which doesn't tend to affect much of anything. And then you have the distal humerus. So when we think about, again, the fractures are in the proximal humerus, so the trabecular groove could be affected. The bicipital groove, which is the trabecular groove, those are both the same thing, essentially, is where the bicep tendon the long head of the bicep runs through there. That could be an issue. So we just have to think about those things as we're, again, thinking about what this fracture might look like. It's more likely that the surgical neck is going to be damaged rather than the anatomical neck. So just keep that in mind as well. A little more distally is usually where we end up with fractures. So blood flow to the proximal humerus, that's also can be an issue depending on where the fracture is. So you'll see that this area is where we have the axillary nerve, median nerve, and ulnar nerve traveling pretty close, especially the axillary and the median nerve. So if it's a bad enough fracture, those nerves could be affected. And then we have the axillary artery as well that kind of travels around and provides blood flow to the humerus. So that's something we have to kind of consider. Could be also affected if it's a bad enough fracture. The most likely injury that we get, especially if there's traction, meaning that the arm gets kind of pulled on with a fracture, the most likely injury is to the axillary nerve. So you guys have probably seen a little bit of that kind of thing before. Axillary nerve is usually affected with those surgical neck fractures. And so if you guys remember your innervation of muscles, that's going to affect the deltoid, and it could also affect the teres minor. So if the axillary nerve has been damaged, we have to think about just overall kind of overhead movements, and then teres minor we know does external rotation. So those things could be affected if there's some nerve damage. Avascular necrosis can happen. I'm not sure that it's incredibly common. I haven't seen it a whole lot, but again, if you look at the anatomy of the blood flow to the area, there's the possibility that with a fracture we lose the possibility of getting good blood flow to the head of the humerus. So this oftentimes is going to happen to older people, especially women, and it usually occurs because of a fall. So they're going to put their arm out in front of them, that outstretched arm, and all of the power, all of the force from the ground is going to go up, and it's going to then lead to a fracture of the proximal humerus. So we sometimes will see it in younger people, but it tends to be a fall type of injury, older population. Diagnosis, just like with any other fracture, the most common way to diagnose it is with an x-ray. They're probably going to also consider the mechanism of injury. So again, high velocity type of trauma is most likely to cause the fracture. there's usually always going to be some irritability around the fracture site. So there's no special test that we would do for this kind of fracture. Usually there's going to be irritability around the shoulder. So there was some sort of trauma. We're going to do an x-ray. Our non-operative treatment is going to happen if there's a very little displacement of the fracture. So the fracture is lined up really well. Maybe it was a very, very small hairline type fracture, something like that. Then they're going to say, okay, we don't need to do any hardware. We don't need to do any type of surgery. And so instead, and I would say I've probably seen about 25% of the fractures that I've seen in China have been non-operative for proximal humerus. So, it does happen somewhat frequently in China that they're not going to do surgery for this one, which is kind of good because as we talk about all these different fractures, these different areas, you'll notice that surgeons really love to put hardware in our patients with a fracture, sometimes when it's not even necessary because they get paid better. So it's unfortunate but true. I think probably they tend to do more surgery than necessary. But I think with this patient population, most of the time when they're doing the surgery, it's appropriate, it's justified. So if they're not doing surgery, they're going to immobilize them in a sling. And then usually around 2 weeks, we can start doing passive range of motion activities. We want to get full range of motion usually by 8 weeks. Remember, this is a non-weight bearing bone, right? So we have to think about doing movement as much as we can and making sure we keep range of motion, which we're going to talk about. Range of motion is a real problem with a lot of these patients. They get immobilized for too long and they are limited in their range of motion. So our goal is to get range of motion, full range of motion actively by 8 weeks. And we're starting passive range of motion, hopefully around 2 weeks. So hopefully they're just in a sling that allows for you to take them out of the sling and you can start doing some passive range of motion at 2 weeks. You then start strengthening after about 8 weeks. So you also really need to consider why they fell. So this is something we're going to talk about with every one of these fractures, or most of these fractures, is, okay, was this a balance problem? Was there other things that happened that, maybe like a blood pressure problem that led to them falling? And so you need to address those things as well. So even though this is a shoulder fracture, you may be working on balance activities and things like that with these patients to help decrease the likelihood of another injury. So surgical, they're going to do a surgery if it's a displaced fracture. A picture on the left is kind of disturbing. So if it's displaced, if there's multiple areas of fracture, so multiple fragments, and then they're also definitely going to do surgery if there was an issue that the injury might have affected a nerve, or multiple nerves, or they're worried about blood flow. Then they're definitely going to do some sort of fixation. So surgery is just basically repositioning and putting in a bunch of hardware. You're going to see the surgeries for the fracture group. These are not terribly complicated surgeries. The surgeons get to just kind of show off their ability to do some mechanical work here. So they may use plates and screws. They may only need to do screws, like you can see in that top picture on the right. A percutaneous volar approach tends to have the best clinical outcomes. I don't know that that's helpful for us, but it does allow them to kind of, again, not affect the muscle as much, because you remember there's a lot of muscles attaching right around where that fracture is. So if they're able to come up from the bottom, essentially, that's what a volar approach is, they're less likely to affect all those muscle groups that are attaching right around there. Complications, the biggest complication is probably a vascular necrosis. The second one would be some sort of brachial plexus injury or infection. So brachial plexus injuries, we definitely need to make sure we're asking, and this is kind of true, well, with any fracture, any injury at all, but with upper extremity injuries, I think it's really important that we're asking about sensation. So is there any change in their sensation? Is there any ma-mu that's not just related to the surgery, but maybe related to the injury? So make sure you're asking about that with this population. You know, they may have had to do some surgery to to help with the nerve, but it's not likely that they did. They probably just figured, let's get the bone in the right place, and then the nerve can heal on its own. So you may end up having to do some nerve glides and some soft tissue work around the nerve to get that nerve to be more mobile as well. So they're going to be in a sling, and so we want to make sure the patient knows that beforehand. If you can talk to them beforehand, they're going to wear a sling usually for about 4 weeks, and they're non-weight bearing, so meaning they're not putting their hand down to push through their hand, they're not putting their elbow down to push through their elbow for 4 to 6 weeks. That doesn't mean that they can't get out of the sling and we can't do treatment with them. What that means is you don't want to obviously be putting huge amounts of pressure straight through the joint. But we know that loading is good, so again, we'll talk about that as we talk about the specifics of rehab. So I think it's always helpful, if you can, to teach the patient how to use a sling before surgery. It is also helpful to do it immediately after if you don't have that option. But for those of you who are in hospital settings where you might be able to see the patient before the surgery, even if you're just seeing them for, 15 minutes to show them how to use a sling, once they're immediately out of surgery, they're going to be groggy, and it's going to be harder for them to focus. So if you can, even though they've had the fracture, you can definitely still kind of show them how to put on a sling and teach them then, and then you can teach them afterwards. You also want to make sure they understand that they should not be weight bearing on that arm for a period of time, and kind of go through a little bit of that time frame with them. That can always be helpful. So first 4 weeks, this is our protective motion phase. And during this phase, as always, we want to control pain and swelling. We don't usually see a lot of swelling, but there is definitely pain. If you remember when we talked about rotator cuff, and we've talked about some other surgeries for the shoulder, shoulders are the most painful, I think, basically the most painful area to have surgery or injury of anywhere in the body. Our patients tend to really, really struggle after these injuries, after these surgeries, for at least a couple of weeks. And muscle guarding is really significant, and just difficulty sleeping. All of those things we have to think about with this patient group. So we're really trying hard from the beginning, if you can see them early, to find ways to help them with their pain. Also finding ways to do some sort of conditioning, walking or biking, or not cycling outside, but maybe a recumbent bike or a stationary bike with the sling on is also something that's kind of important, just to keep them moving, keep their thoracic spine moving. And then we also want to make sure that unaffected joints, so wrist, hand, cervical spine, when you wear a sling, the neck can get really irritable, making sure all of those things are moving very well. And then our other big goal is we do not want to end up with a frozen shoulder or decreased mobility of the glenohumeral joint. So we want to make sure the patient knows that we're going to be doing a lot of passive range of motion as early as possible. So that's part of a big piece of patient education. We also want to make sure they know that they can do active range of motion at the elbow, the wrist, the hand, and the neck. So we can't be doing active range of motion at the shoulder during this first phase, but every place else is fair game. So we want to make sure that they can recognize that they should not just be not moving in a sling for the first 4 weeks. Okay. If they are a smoker, we really want to encourage them to just take a break from smoking for this healing process. I have seen a lot of smokers after shoulder fractures in China. This is the patient population that tends to not heal well, so we end up getting them in rehab. And they're irritable, their shoulder, doesn't move very well. And we start having the conversation and we find out that they're a smoker. it's one of those things where, I mean, I literally would just tell them, look, I understand it's hard to not be smoking, but if you can just take a break for 8 weeks to let this shoulder heal, it definitely can make a difference in your function. So our treatment modalities, we really want to make sure we're doing pain control. They should be wearing that sling. We need to teach them how to put that sling on. We monitor them about that weight bearing restriction. We then do gentle active range of motion. So we're teaching them, okay, moving your head, keep your head moving, keep your wrist and hand moving, keep your elbow moving gently. And then for us, we're doing passive range of motion. So again, anybody who was in my upper extremity course, you know that I kind of do this dancing thing with the shoulder to keep it relaxed. These patients, this first phase especially, these first 4 weeks, they're not going to want you to touch their shoulder. So you really have to do really nice technique where you're just kind of, hugging that arm to your body and literally just kind of dancing around with the arm. And providing just a little bit of distraction. Obviously, you have to be careful, but you can do a little bit of distraction, and then just allowing the muscles around the shoulder that are all going to be guarding and holding that shoulder from stopping that shoulder from moving, allowing those muscles to fonction and relax so that you can get that arm moving better. So external rotation to 40 degrees, which actually is kind of a lot. I think, during this first phase. So keep that in mind, 40 degrees. And then supine elevation. We don't really have any restrictions on passive range of motion, but we do want to be doing it in supine because we can stabilize a little bit better. And the patient's less likely to guard. They're much more likely to be relaxed. They're not going to feel like they have to turn on muscles as much if you keep them in supine. So we really are doing most of our stuff in supine. We talked about pendulum exercises. We talked about those before. I am not a huge fan of pendulum or Codman's exercises. I just think they're way too hard. Patients do not know how to relax. They don't know how to turn off their muscles. So, it's suggested here, if you can teach a patient how to do it the right way, using their hips to move their body, great. Some patients, if they do it right, they can relax and it works out fine, but a lot of them can't. Starting like second week, third week, you can start doing more active assistive range of motion. So that's going to be using the cane, like the picture here. So you can do external rotation with the cane. You can do overhead, like forward elevation, and then a little bit of internal rotation and extension. And then you're also going to be spending time making sure the scapula turns on, okay? So you can do scapular exercises with the sling on. You can do scapular exercises with the sling off. I think sometimes patients will say that their shoulder gets really irritable when the sling is off trying to do scapular stuff. So you probably will find that they're happier with scapular exercises wearing the sling. But if their irritability's level is low, go for it. Take the sling off, do some scapular stuff. Obviously, these other exercises, no sling. And then by week 3 to 4, this is actually when we can start doing some isometrics. So we're doing kind of submaximal isometrics during week 3 to 4. So you're putting them in the positions just like the picture. That first picture top left is going to be your flexion. You can do extension, you can do abduction, and then the pictures on the right are your external and internal rotation. So when I say submaximal, I would say tell them, okay, maybe think about going 30 to 50%. With, isometrics, have them hold 5 seconds, sets of 10 or 15, really dependent on irritability level. They should not have increased irritability after the exercise. So just kind of watch that to make sure that they can tolerate the amount that they are doing with isometrics. So kind of monitor that. But they should be fine doing those isometrics, keeping that shoulder in a neutral position. So we're moving to the next phase. Really, it's dependent on what the doctor says, but we want passive elevation at 120. It's kind of our goal. External rotation, it says 45. We said 40. I really think you're pretty good at 40. I wouldn't try to push it too hard during the first phase. I think you're fine going 40 degrees, but do try to get that external rotation. That external rotation, there's going to be a lot of guarding. It's going to be difficult for a lot of your patients, but see if you can get there by week 4. So the second month is when we can start doing more real active range of motion and a little bit more loading. So our goal is to get full range of motion, active and passive, and actively use that range of motion so they're not fearful of using the range of motion, and we want to be increasing strength. So by the second month, they really should be out of the sling, but you'll notice again, depending on irritability level, pain levels, they may like wearing the sling for short periods of time. As we also know, if they're returning to work or they're going to be surrounded by a lot of other people, having the sling kind of keeps people away. So crowds, people say, oh, there's something wrong with them, so I'm not going to bump into their shoulder because there's something wrong with their shoulder. So that's helpful too if they need to wear the sling in like public places. During the second phase, which is the second month, we're not doing any lifting yet. So we need to make sure they know that. But we can start doing active range of motion. So we're going to start in supine with active range of motion. So just reaching the arm overhead actively. We can then start doing that stuff with weights once they can tolerate it with no pain. So full range of motion with no pain, then we can add weights. We can also do that active assisted range of motion now in standing using a stick or, a cane or whatever you have. They can start doing that actively not in supine anymore. And then with pulleys, we kind of want to consider eccentric control. So pulleys can be a little tricky. We have to make sure that they're not like going crazy with overusing muscles and causing bad movement patterns. So you can have them kind of passively bring the arm overhead and then slowly with control bringing the arm down using pulleys. That tends to be a pretty comfortable way and a good way to work on that overhead movement. So to progress from the second month into the third month, we want to make sure that they have pain-free range of motion, at least 90%. You guys, again, I think the problem with most of our patients in China is that we don't get them the first 2 months. So some of the patients have enough range of motion, they don't complain to the doctor. So you maybe don't see them until month 3 or 4, and so then they're stuck. And that tends to be the problem. So if you do get them early, which we hope that surgeons start to do that a little bit more frequently, if you do get them early, I think it's fair to say that by the end of the second month, they should have pretty close to full range of motion. They should also be able to do those isometrics, so resisted exercises without a whole lot of movement. They should be able to do isometrics without pain. So those are, and full-on isometrics. So instead of that 50% or less of their force, they can do 100% without pain. So phase 3 is going to be our sensory motor training. Again, this goes to 3 months. So you'll see that really this is what you're going to notice is a trend with all of our fractures. This patient should be pretty much healed. That callus should be formed by 3 months. And we really should be able to kind of get back to normal life by 3 months. So it's during this time period that we're focusing our goals on increasing strength through the range of motion. So what you're going to find, again, with this patient population, especially if you're getting them later, so like at month 3 or 4, is that it's not just a range of motion problem, it's a strength problem. And again, they're pretty much healed by the end of the 3rd month, definitely by the end of the 3rd month, sometimes even by the end of the 2nd month. And so you have the ability to really get pretty aggressive with their range of motion, and you've got to be working on strengthening during this 3rd month. So it's really important that their rotator cuff strength is good. If you remember, again, if something like the axillary nerve was affected or any other nerves were affected, that can affect the rotator cuff. Also, depending on how they did the surgery, the rotator cuff could be affected. So you really want to make sure you're checking external rotation strength especially, but also internal rotation. Our goal is that by the end of 3 months, they can set that head of the humerus in the glenoid, keeping that position really, really stable. And they do that by using their rotator cuff to turn on and allow for overhead movement with the right movement pattern and the right positioning of the head of the humerus. We also want to really focus on scapular strengthening during this period. And you could certainly have done scapular strengthening during the 2nd month, but it's during this 3rd month that the scapular strengthening is going to be important to get that scapular thoracic rhythm, again, which works with the arm going overhead. So we want to make sure that the patient is returning to normal ADLs during this period of time. They can be lifting. They can be using that involved side. And so we want to make sure that they are not scared and fearful and like just limiting the use of that arm because of the fracture. And, you know, I mean, I get it. These patients, if you can get them to go in and talk to a doctor and get an x-ray, where the doctor can then say, oh, yes, your x-ray looks great. They're much more likely to do that. They're much more likely to say, okay, I'm willing to use my arm. And that's fine. If the x-ray is what's going to convince them to do it, that's fine. But recognize that by this point, as long as there isn't a complication like avascular necrosis, their bone is healed and they should be able to go back to all their ADLs. Treatment is going to focus on, again, resisted strengthening in different planes. So we're moving away from the isometrics. We're starting to use things like TheraBand. We're starting to use things like weights. We can now weight bear on that arm. So remember, we said 6 to 8 weeks of non-weight bearing. We can now put weight on it. So we can do things like push-ups and pushing off of a bed or pushing off of a chair. And, you know, putting the elbow on something and weight bearing through the elbow. All of those things are okay now. We can use things like an arm bike, which is always going to be helpful for not only range of motion, but also cardiovascular exercise. And then, again, depending on when you get to see them the first time, if you're not seeing them in those first couple months, and you're not getting them until month 3 or 4 or 5 or 6 even, the soft tissue has gotten probably pretty tight. So you probably are going to be spending time trying to get the glenohumeral joint moving better, doing joint mobility, but you might also need to be doing a lot of soft tissue work. So stretching into external rotation, internal rotation, flexion. You may have to do like a hanging stretch, like with elbow extension and arm extension. I wouldn't say you just like literally have them hang off of a bar. That might be a little bit too difficult. Again, remember, this is an older population. But what you could do is just have them unload. So try to get their arm up as high as they can, grab onto something, and then just sort of bend their knees a little bit. So like if you have a finger ladder or one of those other things where the bar is not all the way up like really high, but high enough where they can grab onto it, and then just kind of, you know, both hands grabbing onto that bar or that whatever, and then just letting themselves hang. So letting themselves unload a little bit, that's okay. Again, by this point, that fracture is healed. So you should be able to do that. So I don't have a return to sport slide here. By month 3, end of month 3, remember, they should be fine. So you really can give them back to sports. These are just older patients, so they're usually not getting back to really intense sports, but you know, you can certainly start doing sport-specific stuff after 3 months. So that is proximal humerus fracture. Again, these patients, unfortunately, in China, you're not going to get them usually early enough to really have great outcomes. So you're going to just be doing a lot of joint mobilization, a lot of stretching, a lot of strengthening once you have that range of motion. Because you're usually getting them if they're really tight and stuck. So that makes your life a little bit more challenging.